Today I'm going to be discussing chest tube insertion. Indications for a chest tube insertion include pneumothorax, hemoneumothorax, empyema, pleural effusion, chlorothorax, hydrothorax, pleurodesis, or status post-thoracotomy. The NP should be familiar with competent in the procedure before proceeding. They should also be familiar with the anatomy of the thoracic cavity. They should also be familiar with any contraindications for placing a chest tube. A absolute contraindication for placing a chest tube is if the lung is densely adhered to the chest wall cavity. Relative contraindications include coagulopathy, giant blebs, or if the patient has multiple adhesions. The NP should check a PTI and iron platelet count if able, and reverse any coagulopathy or a platelet defect. Again, these are relative contraindications, so if re-expanding the lung would supersede those. The chest tube selection size is determined by why the chest tube is being placed, and also the location of the insertion is dependent upon what you're placing the chest tube for. If you're placing a chest tube to remove air, the chest tube is placed at the apex of the lung at the second intercostal space. If you're placing it to drain fluid, it's placed at the base of the lung at the fifth or sixth intercostal space. If you're dealing with a hemopneumothorax or a traumatic hemothorax, a large bore chest tube is used size 36 to 40 French. If you're using it to drain a pleural effusion, a medium-sized tube 24 French to 36 French is used, and for a pneumothorax, a 12 French to 24 French bored chest tube is used. Equipment needed for the procedure include cap, mount, mask, sterile gloves, goggles, and drape, antiseptic solution, and a local anesthetic, usually lidocaine 1 to 2% with or without epinephrine is used. You also will need a 10 ml syringe with a 20 gauge 1.5 inch needle and a 5 ml syringe with a 25 gauge 1 inch needle. A chest tube tray is also needed, and that will include your sterile towels, 4x4s, 10 or 11 blade scalpel, 2 Kelly clamps, needle holder, sutures, a sterile basin, suture scissors, 2 hemostats. Other supplies needed are the chest tube itself, a closed chest drainage system, a suction source, a suction tubing, adhesive tape, and an occlusive dressing. Patient and family education should occur if able. The NP should understand the level of understanding about the patient's condition and the reason for the chest tube insertion. They should also be informed that they'll sit semi-Fowlers post-procedure to facilitate drainage, that they can continue to turn side to side, making sure the chest tube doesn't kink, that they can continue their activity as long as the drainage system remains below the level of the chest, and that they should encourage active or passive range of motion on the affected side. A pain management plan should also be in place post-procedure. The NP should have an assistant with them at the bedside to help with the insertion of the chest tube. The assistant will help monitor the patient, also set up the sterile tray. A timeout should occur with another provider or an RN. The patient should be identified using 2 patient identifiers. The correct procedure should be noted, and the site should be marked. The patient should be placed in a supine position with their hand placed over their head. Analgesics or sedatives should be given pre-procedure. Supplemental oxygen should also be given, and pulse oximetry and end-tidal CO2 needs to be monitored intra-procedure. The provider should don sterile mask, eye protection, cap, gloves, and gown. The assistant should open the outer wrapper of the insertion tray and open using sterile technique. The NP is to ensure all equipment is present. The assistant will pour the antiseptic solution into a basin and then open the chest tube package and place it onto the open tray sterilely. Then they will assist the provider in drawing up the lidocaine. The NP grasps the suture needle with the needle holder, then removes the trocar from the chest tube and grasps the proximal end of the chest tube with a Kelly clamp. Next, the insertion site is identified and an immediate pre-procedure timeout is performed again. The skin is prepped with the antiseptic solution and the sterile drape is placed surrounding the insertion site. The area is then anesthetized 1 intercostal space below the insertion site with a 5 ml syringe by injecting a subcutaneous wheel of lidocaine. Then with a 10 ml syringe, the NP will advance the syringe, aspirating as she goes until air or pleural fluid is confirmed, and then inject the lidocaine deeper. Slowly withdraw the syringe, anesthetizing the rib, periosteum, subcu tissue, and the pleura. Next, a transverse incision should be made the size of the diameter of the chest tube directly over the inferior aspect of the anesthetized rib below the insertion site. The NP will introduce the Kelly clamp through the incision with the tips down, creating a tunnel through the subcu tissue and muscle using an opening and spreading maneuver, aiming towards the superior aspect of the rib until the pleural space is reached. Additional lidocaine can be given as needed. When the clamp is just over the top portion of the rib, the clamp is closed and pushed down with steady pressure through the parietal pleura into the pleural space, then widen the hole in the pleural space by spreading the clamp. The index finger is used to dilate the tract and hole in the pleura. Next, the chest tube is inserted into the chest cavity with a curved Kelly clamp, holding the proximal end to guide the tip into the pleural space. The clamp is then removed while guiding the tube in a rotating motion until the last hole is in the pleural space. At this point, condensation of air or fluid in the tube should be seen. Next, the chest tube is connected to the closed drainage system and titling should be assessed for, and the assistant should place the chest tube to suction. The chest tube is then sutured to the chest wall, and then the sutures are wrapped around the tube and tied snugly at the top of the tube. Next, the occlusive dressing is applied and secured with a tape dressing. Lastly, a chest x-ray is obtained to confirm placement, and monitoring of the patient continues closely. Thank you.